Hello guys. This is Dr. Tino Finland speaking. I don't know if you guys know that my other passions in life is sharing information. I love to teach. I enjoy teaching. And I am that medical intern that whenever there is an opportunity to share with the students, with the interns sometimes, I normally take that opportunity. So since last year, the students have been asking me to make videos just to explain those crucial concepts in medicine, be it in a gynae, be it in a surgery, internal medicine, and all that. And I've been reluctant to do that. And the channel that I've opened, my number one passion is to preach the gospel. All these other things, they follow. So I will think about opening a channel. I'm not sure if I will do it, but I'll think about it. But because they've been persistent, so I've decided to do this one. Maybe I'll continue. I don't know, but we'll see. So what I want to talk about today is antihypertensives. There is a way that I devised when I was doing final year of remembering almost all the antihypertensives. So that's what I'm going to cover. So this is like antihypertensives in one page. Okay, let's go. So let's start by this formula. This is a physiological formula. It says P is equals to cardiac output multiplied by peripheral resistance. So that's a formula that we know from physiology. So since it's a multiplication formula, we know that when we increase cardiac output, then blood pressure will increase. And the opposite is true. When we decrease cardiac output, blood pressure will also decrease. When we increase peripheral resistance, blood pressure will increase. When we decrease peripheral resistance, blood pressure will also decrease. So, but we also know that cardiac output is a product of stroke volume multiplied by the heart rate. So we know that cardiac output is the amount of blood that is ejected from the heart per minute, while stroke volume is the amount of blood that is ejected by the heart per beat. We also know that stroke volume comes from preload contractility and afterload. This is what we already know, but yeah, so if you know this, you're already a step ahead of me in this teaching. So stroke volume, preload is I want you to look at preload as the amount of blood that makes it to the heart, meaning venous return. And venous return is dependent on blood volume. So if you decrease a patient's blood volume, you will decrease their preload and decrease their stroke volume, decrease their cardiac output, and eventually decrease their blood pressure, which is their hypertension. So what are the drugs that can decrease the blood volume? It's your diuretics. Because my handwriting is so bad, I would advise you to write this as I go on as well for yourself. So diuretics, there are three classes there. We've got loop diuretics, we have thiazide, and we have potassium sparing diuretics. For loop diuretics, we have Lasix there, which is furosemide. For thiazides, we have HCTZ, hydrochlorothiazide, or also known as Reduc. The other one there is indapamide. Indapamide is not available in the public sector, but you will find it in private. There are so many patients who are taking indapamide. And then potassium sparing is aldactone there. There's aldactone, or another name for it is spironolactone. Ne? So yeah. So the drugs that you can use to decrease a patient's blood volume is one of these three drugs, with the hope that you will eventually decrease your blood pressure and control your patient's hypertension. Let's move on to contractility. Contractility is the forcefulness, is how forceful the heart or the cardiomyocytes contract in order to have a good cardiac output. This guy. For a heart muscle or a heart cell or cardiomyocyte to contract, it depends on the influx of calcium ion. So if you can block calcium from entering into the cardiomyocyte, then you will sort of like render that a muscle, you will paralyze it. You will make it to be weaker in its contractility, contract with less strength or less power. So the drugs that you can use to prevent calcium from entering into the cells is calcium channel blockers. And the drugs that you find there is your nifedipine or adalat. The most commonly used one is amlodipine, also known as Amloc. So please write them as I say them so I don't forget. Nifedipine, also known as adalat, or Amloc, also known as amlodipine. Comes in dose. This one shouldn't be mentioning doses here, but if you want to quickly know the doses, Lasix starts from about, in peds it's per kg, but in adults it's mostly 20 milligrams, 40 milligrams, 60, 80, 100, depending whether you are managing hypertension or heart failure. Indapamide is normally 2.5, even 5 milligrams. HZ, you normally start at 12.5, 25 milligrams. Spironolactone 25, 50 milligrams. I've seen patients having on 100 milligrams of aldactone. Amlodipine is normally 5 milligrams, 10 milligrams. Nifedipine, there's 5 milligrams, there's 10 milligrams, like that. And then, yeah. Okay, afterload. Afterload is the amount of work that the heart has to do, or is the amount of resistance in the peripheries that the heart has got to overcome in order to eject successfully. So the higher the afterload, the harder the heart has to work. So the heart doesn't want to work hard. So if you've got a high afterload, then your heart will work hard, and and this will increase this, and this will increase, and then this will increase. So you want to decrease this, like we decrease this and decrease this, so you also want to decrease this. So basically you can look at afterload as a systemic vasal constriction, or let me say narrowing. So if you've got narrowing of your arteries in the system, like your aorta and your other vessels, if they are narrowed, it means that there's a high afterload. So the things that can narrow your arteries, it can be arteriosclerosis, which is fibrosis of the arteries, or atherosclerosis, which is just a plaque that forms inside the lumen and make the vessel to be narrow. You can also have yeah, as long as there is narrowing, you can have uh, those are the most common ones. Like old people who've got hypertension, they have arteriosclerosis. Those who are diabetic and with dyslipidemia can have a combination of atherosclerosis and arteriosclerosis. So what you want to do there, you just want to vasodilate them. So when you vasodilate them, you are decreasing the afterload and making the heart not to work hard. So the drugs that you can use there is your vasodilators, AC inhibitors. AC inhibitors. AC inhibitors, most of the times, antihypertensive that have got a suffix of pril, like the end with pril, are your AC inhibitors. So drugs like enalapril, captopril, perindopril, those are your AC inhibitors, angiotensin converting enzyme inhibitors. So yeah, the most commonly used one is enalapril, which starts from 2.5 milligrams, 5 milligrams, 10 milligrams, up to even 20. And ACE inhibitors are a BD dose. They are a BD dose. They are a 12-hourly drugs. Another drug that also vasodilates is hydralazine. Okay, now let's move on to heart rate. If we want to decrease heart rate and hopefully decrease cardiac output, with the hope that we decrease blood pressure, then the drugs that we can use there are beta blockers. Remember, we've got receptors. We've got beta 1, beta 2, beta 3. Beta 1 is found in the heart and in the arteries, and then beta 2 is found in the airways. So which means if you give a patient a beta blocker that is non-selective, a beta blocker can be selective or non-selective. So they are either beta 1 or beta 2. I mean, there are either beta 1 or beta 1 and 2. So beta 1 and 2 is non-selective. It blocks both beta 1 and beta 2. So you don't want to use a beta 2 blocker to treat hypertension on a patient that has asthma, COPD, bronchitis, any airway, any disease that affects the airway of the patient. You wanna run away from a non-selective beta blocker, because that condition that they have will just be exacerbated. So it's better to use a selective one. So there you've got drugs that you can use: atenolol, propanolol. The most beautiful one is carvedilol. It's loved by cardiologists. It's good for hypertension and even better for heart failure. It's a beautiful beta blocker to use for heart failure. It has been proven to be an antihypertensive and an anti-failure drug. It's very beautiful. So those are beta blockers. Remember, with beta blockers, you run a chance of having bradycardia, which is a heart rate of less than 60. Okay, let's just okay, let's come back here. I'm forgetting something here. Another class of drug that you can use is called the ARBs, under vasodilation. ARBs, angiotensin receptor blockers. Angiotensin receptor blockers. These drugs are not very common, but they are there. Most of them are your Satans. Satan. They end with Satan at the end. SARTAN. So just look them up. ARBs, angiotensin receptor blockers. Yeah. So okay. Lastly, peripheral resistance. Peripheral resistance is not very different from afterload. So it's resistance that is in the arteries that you need to overcome to eject blood. So same drugs there, AC inhibitors and ARBs. So there isn't a difference. While I'm at it, why is it important for us to make sure that we screen patients who are hypertensive? We screen them for dyslipidemias like hypercholesteremia or whatever dyslipidemia that they might be having. The reason for that is that when you have diabetes or hypertension, you are at a risk of having dyslipidemia or hypercholesterolemia. So when you have those, once you start forming plaques in those big arteries, you are increasing peripheral resistance and also afterload. So your heart will work harder and you will get heart failure eventually, because you would have increased your afterload and your peripheral resistance. So it's important. A patient who's hypertensive, the last time I checked, every year they are supposed to be done a lipogram, regardless of whether they are on statins or not. Maybe one day I'll talk about heart failure, talk about dyslipidemias, because yeah. Okay, let's quickly talk about side effects. So okay, before I talk about side effects, so now how do you treat a patient who's hypertensive? A patient who's hypertensive, let's say you are convinced that the patient is hypertensive because you have run tests and you are sure that this is hypertension and they've never been hypertensive before. So it's the first time that you're diagnosing them. So the drug of choice in black patients is diuretics. You can either start them on a thiazide, either on a reduc or on a indapamide. That would be your first drug that you'd use. And then if maybe they don't tolerate it, or let's say they are not controlled, then the second line would be an AC inhibitor, the most commonly used one. So the most commonly used diuretic for treating hypertension is HCTZ or reduc, and the most commonly used AC inhibitor for treating hypertension is enalapril. So that's why you find most of the patients in the hospital, they are on reduc combined with AC or just reduc alone, and like that. So but if you go to other places where they are, you might find like for instance white patients. White patients, majority of them, they do much better on an ACE inhibitor as their first line, rather than the diuretic, the thiazide diuretic. That's why now you'll find someone who's got this kind of patients, you just find them that they are taking one drug, and that drug is ACE, which you know it to be a second line in other patients. So there's that as well. So yeah. So side effects. Okay, side effects. All antihypertensives has a potential to cause hypotension, low blood pressure. Number one. Number two, any drug that you take orally has got a potential to cause nausea, vomiting, abdominal pain, diarrhea. Now let's go to, okay, anyone can react on anything, so allergic reactions can also be there for any of these drugs. And then let's now go to specific classes. When you talk about diuretics, loop diuretics, they are known to cause hypokalemia, and then thiazides are known to precipitate gouty arthritis. So if you've got a patient who has got gout, then they just keep coming with flares, then you might consider switching them from a thiazide to a different diuretic. And also they are also known to cause ED, which is erectile dysfunction. Those are diuretics. And then when you talk about, okay, potassium sparing drugs like adultone, because they spare potassium, so they have a potential to cause hyperkalemia. And then ACE inhibitors, the two side effect that is troublesome when it comes to this class of drugs is what is called angioedema. Angioedema, your patient will come in with swollen lips, like very swollen tongue. Some of them might even come not with difficulty breathing. They can't even talk. And then that's your angioedema. It's so bad. It looks like anaphylaxis when you look at it. But obviously, you don't have the systemic manifestations. So these are that and this persistent dry cough that they also get. Those are the two reasons why most patients are stopped from taking these drugs. So so they get a cough that is dry, that is just irritating, and these kind of patients, you can investigate them for the whole year. You won't find a cause up until you stop the ACE inhibitor. So why do they get this kind of cough? It's because, remember, the angioconverting enzyme is found in the lungs. So when that enzyme is inhibited, basically you allow the buildup of bradykinin in the lungs, and it's a cytokine that irritates the airways, and the patient starts coughing and coughing and coughing and coughing and coughing. Yeah. And yeah, side effects I have mentioned for beta blockers, that bradycardia, even calcium channel blockers can give you bradycardia as well. So I think that's that for antihypertensive. So it's antihypertensives on one page. I hope you will share this with students, and let's be better together. I hope you enjoyed this information sharing session. Thank you so much. Bye.